I think we talked about first-line therapy and things that drive selection of first-line therapy. And patients do well for many years, but some of them do relapse or progress on treatment. And so therapeutic sequencing is a very important concept. There's not a lot of data around that, but I wonder, Dr. Allan, if I could ask you to give us your thoughts on what are the major concepts with regard to therapeutic sequencing. For example, if we start with a BTK inhibitor, what do we do next if a patient progresses, and where are we trying to get that patient for long-term disease control? Also starting with a BCL2 small molecule inhibitor, what's the sort of sequencing strategy in that case?
Yeah, so that's a great topic and a hot topic, and something that we don't quite know the answer if there is a best sequence for our patients. And really the only way to do that is start them out on one and have a long-term study that then follows them switching to the therapy upon progression. And because these patients do so well in following that PFS2, depending on your sequence, that'd be really the only way to truly identify that, and that's just never going to happen, just because you need large numbers of patients and long-term follow-up. So what we're left at is really looking at studies that have been performed where it was one of the inclusion criteria is exposure as the prior therapy to let's say a BTK inhibitor or BCL2 inhibitor. And the only prospective clinical trial that's been designed and reported and published in that manner is looking at true ibrutinib progressors and intolerant patients and salvaging them with venetoclax. And this was a smaller phase 2 study where they took these patients that had true progression and or intolerance. And in this study, I think it was close to 100 or so patients, somewhere around there. The vast majority, over close to 60% actually had true progression on BTK inhibitors. Mind you, relapse refractory, heavily pretreated patients in the era of earlier BTK use, to where we're hopefully emerging from. So we won't be treating these types of patients anymore. But what we found is that venetoclax is great salvage abilities, and basically response rates were close to 70%. CR rates were relatively high in this refractory patient population. Peripheral blood MRD rates were in the 40% range. That didn't necessarily translate to deep bone marrow disease negativity. Not a lot of patients had that, so that's a little unknown there. But what we found is, and what we've shown is that if you can get to an NMRD negative state, those patients had a progression-free survival that wasn't met at the time that they had reported. They'd never had another follow-up. But overall, patients had a PFS of about 2 years when they get salvaged with venetoclax. Again, very highly refractory patients that had previous progression on BTK inhibitors. So that is typically the classic standard of care. If you start a BTKI inhibitor, we then flip to a venetoclax or a BCL2 inhibitor-based treatment. Whether or not you add an anti-CD20 or you do fixed duration, that's based on the Murano data a little bit. Though in Murano data, it's important to remember that only about a very small numbers of patients in the total patient population had prior BTK inhibitor exposure. So we didn't get our answer from that study. Ultimately, though, you do some venetoclax-based treatment typically. We do know that based on some real-world evidence and just personal experience and kind of cross-study comparisons, that switching to other B-cell receptor antagonists like a PI3 kinase inhibitor after a BTK inhibitor progression is probably not going to get you where you need to go. Now, if you come off of a BTK inhibitor for intolerance, PI3 kinase inhibitors can have some activity and get you there, but they have their own issues with intolerance and toxicities and things. So as we said, venetoclax is a very well-tolerated drug. Patients do well. You can salvage these really, tough patients, because we do know if you're progressing on a BTK inhibitor, that disease biology is saying something. That's typically complex karyotype 17p deletion. There is a small subset that don't have BTK inhibitor or BTK mutations, but these patients who truly progress commonly do. And so they need a switch out of the pathway, so to speak. And fortunately, we have venetoclax to do that. The flip side of this is, now that CLL14 is around and many people are adopting and are attracted to this fixed duration, now we're getting a new wave of patients who've been BTKI naive. And we don't have current prospective clinical data of true patients being salvaged with BTK inhibitors post venetoclax progression or relapse. And so that data we're informed from, fortunately, with time. We've gotten some real world evidence data from collaborating groups around the world to be able to put enough patients in relapse refractory settings that had been basically BTKI naive and now have relatively significant numbers in real world settings to where we can see response rates mimic what we see when you use a BTK inhibitor in a BTK inhibitor naive patient, even though they progressed and relapsed on venetoclax. And so that is providing some encouragement from the community, from providers. It is allowing us to at least educate our patients that maybe it doesn't matter so much which drug you use first. You're going to be able to be salvaged regardless of what you use, and it makes sense. These are completely different mechanisms of action. They don't really have crosstalk too much, and basically mechanisms of resistance with a venetoclax or BCL2 inhibitor are very different than the mechanisms of resistance that we see with a BTK inhibitor-based treatment. And so fortunately, what we know is that the sequence doesn't seem to matter too much. You can tailor it a little bit, but classically, you're staying in a BTK inhibitor, then BCL2 pathway, or the opposite. You're not typically doing a B-cell receptor or a BTK inhibitor, staying within the B-cell receptor antagonism and going to a PI3 kinase and then to a venetoclax, because it's probably just not going to get you there. So that's typically my practice. Depends on which one you do first. You use the other class second. And we don't know if their frontline is there, if there is a frontline impact on long-term survival. So if there is a best first-line treatment as of yet. Those head-to-head studies haven't been done. We're kind of getting that, but they're all combinations versus monotherapies and things like that. So exciting times, but that's typically my practice. And I think when talking to my colleagues and other people out in the community, that's typically kind of the train of thought currently.